So welcome back to another video in the basics series. If you're wondering about getting referred to a rheumatology specialist, what is rheumatology, how do I get referred, is rheumatology the best specialty for my condition, and how I can prepare for my rheumatology consultation, then you can check out some of my earlier videos in the basics series. But today we're going to be talking about exactly what happens on the day of the appointment. So we'll start with some real basics. Firstly, you have to know some practical considerations, and forgive me for stating the obvious, but that is things like, where is the clinic located? How am I going to get to the clinic? Am I going to drive myself? Am I going to take a taxi, public transport? And how's the parking situation? Some hospital clinics and outpatient centres are notorious for having really challenging parking, and occasionally that can mean minutes or even half an hour or more just trying to get parking on the day. So doing a bit of advanced research about your particular hospital or clinic can really pay dividends. And in general, especially for the first appointment, I would recommend to attend early and to attend with someone else who can drive you to and from the appointment to significantly reduce the stress on you on what might already be a bit of a stressful day. The other factor is that if it's a really big hospital, finding the rheumatology department might actually take some time. Sometimes they're hidden away in parts of the hospital that aren't easily accessible from the front door, and it can take time to walk there. Once you've arrived at the rheumatology department, you need to check in, and checking in may also involve checking your insurance documents, and that process can take some time. So once you've arrived in the department, most rheumatologists for a new consultation like to have some basic observations. So that means going into a room with one of our nurses or healthcare assistants, having your blood pressure, your pulse, temperature and oxygen saturations checked, maybe your height and weight, and a BMI measurement. You may also be asked to give a urine sample. Perhaps you've been provided with a specimen bottle in advance, but you may be asked to give a sample on the day. So it's worth considering. If you've arrived and then rushed to the loo just before the appointment, you're not going to be in a position to want to give a urine sample. So just remember that when you're coming on the day. You can also ask when you're checking in, is your rheumatologist running to time? Are they running behind? To give you an idea, and taking something to read just in case you're going to be running late, as it helps the boredom. So you'll be called into the rheumatology room, and they'll start by going through details of your symptoms. Now, people might approach this slightly differently. I quite like to understand a little bit of my patient's background medical history to start with, because I find it helps me to focus in a little bit on what I want to know from their symptoms. So I personally may start, unless my patients are keen to get straight into their presenting problem, by asking a few background questions. Are you under the care of any specialist? Do you have any named diagnoses? For example, do you have diabetes? Have you got thyroid problems? Have you got high blood pressure? Have you taken any treatments, or are you currently prescribed any treatments for those conditions? Have you had any hospital admissions or any major surgeries, or is any surgical procedures planned? Once I know the formal medical parts, what prescribed medicines you're on, the dosages, when you take them, I'll also like to ask if you're on anything that you've tried over the counter. Have you tried non-prescribed medicines? Have you tried herbal medicines? Have you been to see any therapists in the recent past? When I understand a bit about your medical history, I normally like to ask about the medical history of your family. Now, it's only really relevant for your blood relatives, so a spouse or an in-law that's not blood related is not so relevant. Generally, we focus on first degree, so brothers, sisters, parents, but we do sometimes go a bit further back, grandparents, maybe great aunts, those sorts of things. Particularly asking about rheumatic diseases, so do you have any history of lupus or rheumatoid arthritis? but also general medical complaints like cancer and diabetes will be asked. As part of the drugs history, we also like to know a bit about allergies, both drug allergies and non-drug allergies. So what happens as well is important. Is it a minor upset of the stomach, or is it full-blown anaphylaxis and you carry an EpiPen for it? Okay, so if I have some information about my patient's backgrounds, I find it helpful. I then usually like to let my patients give me a full detail in their own words of their symptoms before coming in to ask clarification. In general, what I want to know about each symptom is, how did that symptom come on? Did you go to bed one night, wake up and suddenly you had a swollen joint? Or has this been something that's been troubling you on and off, slowly and gradually for years? Over the time frame that you've been having these symptoms, what's happened to them? Are those symptoms gradually getting worse and more progressive? Or does the symptom seem to be easing off? Or does it wax and wane and you have flares intermittently? And overall, what is the duration of these symptoms? Are we talking hours, days, weeks, months, years, or decades? Once I have an idea of the symptoms, I tend to go into each one in detail, and I want to have a full understanding of each symptom. So for example, if you're struggling with pains, which joints exactly are painful? Which joints in the fingers exactly are causing you the biggest trouble? Can you describe the nature of that pain? And there are lots of descriptive words you could consider. Sharp and dull, obviously, but it could be gnawing, searing, burning, tingling, shooting, electric. So I want to have an understanding about the subjective feeling of these symptoms and a grade of intensity. And that can be a bit difficult, but I tend to say, look, 10 out of 10 is the worst pain you can imagine, and 0 is none, with 1 being something fairly minor. If you're coming in with 10 out of 10 pains, it's difficult because if the pains get worse, you have got nowhere further to go. I never challenge anybody on their pain symptoms, but I do think it's worth giving yourself a scope, because if you are 10 out of 10, then by definition your pains are as bad as you can possibly imagine. Once I understand the nature and quality of those pains, I like to ask what the timing of those pains are. Is it something that bothers you at a particular time of the day, for example in the mornings, at lunchtimes, in the early afternoons, or the evenings, or a day of the week, or perhaps it's the weekends or the holidays that are more troublesome? Have you noticed that there's anything that makes those pains become more overt? Have you aggravated the pains by walking on the feet, for example? Is it particularly tender to touch or knock the joints? And have you noticed anything that can improve the pain? So if you applied cold packs or heat packs, have you tried any medications? Do you find that movement might ease the pains? And then finally, are there any other associated features? So do you get any redness, stiffness, swelling, any other features? And I'll do that for every one of the main symptoms, so I have a good understanding of those symptoms and the aggravating features and the timing of those symptoms. So once I've gone through your main symptoms, I then like to go through a series of shorter questions, asking specific and directed questions. And I won't go through all of those in this video, I'll probably put them into another video. But things like seronegative features are important. Some types of arthritis have particular characteristic associated conditions, like skin conditions, for example, psoriasis. I may ask a series of questions about connective tissue diseases. So I may ask about symptoms of dryness in the mouth or eyes, mouth ulcers and things like that. And then I usually run through a quick series of questions asking if you've ever had problems with your heart or circulation. Have you ever had to see a brain specialist or neurologist? Are you stable in your weight, or are you losing weight or gaining weight? To get a big, broad background of your overall health. Before I move on to the examination, I then ask some questions that are more personal to you. So, who's with you at home? Do you have kids at home? What's your job? Are you right or left-handed? How are these symptoms affecting you at home? how are these affecting you in your job role, and a little bit about your lifestyle. What's your diet like? Do you exercise? Do you smoke? Do you drink? Do you take any drugs? And I may ask some fairly sensitive and personal questions, and that could relate to sexual history or pregnancy plans, and these are relevant to rheumatology history. So even though it seems like you're prying and being a bit nosy, they are important questions to ask and can help to work out what might be the cause of your condition. Okay, so I've taken a detailed history. What next? Well, now I need to perform an examination. And maybe you've come in with pain in your hands or pain in your elbow and are wondering why I'm asking you to undress so I can do a full examination. And the reason is that some of the signs that a rheumatologist looks for may well be at a much distant point to the point where you've got symptoms. I usually remember to offer my patients a chaperone. It's easy to forget in the flow of the conversation. You are always entitled to ask for someone to be present, especially if an intimate examination is likely. To wear minimal amounts of clothing is helpful. I'm going to say minimal shorts and a t-shirt is usually fine, so you can see the elbows and the knees. If you need to do a more intimate examination of some of these other areas, then it's sensible to have a chaperone anyway, and your doctor should detail that to you. I usually examine the other organs as well, typically feeling for lymph nodes, having a listen to the heart and lungs as part of your assessment. But it's not always important. For example, examination is much less important if you've come in for concerns about bone thinning conditions like osteoporosis. Okay, so I've taken my history, I've done my examination. Evidence would suggest that makes the diagnosis in about 80% of cases. So that remaining 20% of uncertainty is where our blood tests and investigations come in to help confirm these thoughts or deny them. You might have an area I want to investigate in more detail, and I may have access to some bedside interventions. So I might be able to perform an ultrasound on the day. I might look at the microcirculation of the fingernails using a capillaroscope. I might want to do an intervention. So if you have a great big swollen knee, taking that fluid off will help your symptoms, but I'll also potentially be able to send that fluid to the lab for analysis and maybe inject some steroid for symptomatic relief all at the same time. So you might be consented for some procedures. So I've now done all of the investigation part. Now it's about trying to relay my thoughts and explain that to you. Hopefully I have a diagnosis in mind, but sometimes we don't in rheumatology. I might have a list of things I want to investigate or a list of things I'd like to exclude. So I will then explain to you what's going through my mind, what kind of investigations I want to order. Commonly that will be some blood tests. I may do some imaging like an X-ray, an ultrasound, an MRI, and on occasion some specialty tests might be considered. Lung function, a heart scan, other things could be considered as relevant to your consultation. And I'll give you a brief explanation of what those might be, what I'm looking for, and what I'll do if I find what I'm looking for. If I have a treatment in mind, I'll explain that to you. I may ask you to do some more reading for some of these more detailed treatments, or you may come back for a specific meeting to go through those treatments in detail, because they might have important things you need to be aware of for safety and monitoring. I like to try and give information resources, and most rheumatologists would point you towards perhaps an online resource, or maybe you'll be given a booklet on where to find out more about either the condition or the medication. At that point, I try and summarise what we've covered and make sure that there's no questions, that you don't have any unresolved issues that we haven't covered so far. And then we plan the next stages. So when you leave the consultation, you should have some idea, what do I think is potentially causing your problems, and your rheumatologist will explain that to you. What tests and investigations are likely to be helpful to help confirm or deny that. What sort of treatments might we be starting today or what might be considering once we've got the investigations back, and what timing is going to happen. So when are those tests going to happen? How soon is my follow-up going to be? You might not have all your questions answered. It's pretty common to not remember all of the consultation, which is another reason to bring someone with you on the day to help remember some of the things that were said. But you'll usually have a port of call to contact the rheumatology centre, and in any case, if you're coming back for a follow-up, you can bring up those issues then. I hope you found this useful. If you have any comments or thoughts about your first consultation, or things that you wish you'd known were going to happen in the meeting, I'd love to hear them in the comments section below.